Welcome back to the MediByte channel, everyone. I'm your host, and as a healthcare professional, I am absolutely thrilled to be with you today. We're going to demystify a condition that is incredibly common, yet honestly so widely misunderstood. We are taking a clinical deep dive into Polycystic Ovary Syndrome, or PCOS. Whether you're tuning in for your own health, maybe looking out for a loved one, or just want to expand your medical knowledge, this explainer is designed to give you a complete, detailed, and super easy to understand roadmap of exactly what's going on inside the body. Okay, let's dive into our clinical roadmap for this explainer. We'll start by understanding PCOS, then look at the hormone and insulin link, recognize the symptoms, go through diagnosis and rule-outs, talk targeted treatment and management, and finally wrap up with reclaiming your health. Let's get right to it.
Section 1. Understanding PCOS. We really need to grasp the true scale of the problem here.
So PCOS affects roughly 5 to 10% of women. I mean, think about that. That's a massive portion of the population dealing with a deeply complex hormonal issue. But what's even more striking is the clinical fallout from this. In the United States alone, PCOS is literally the single most common cause of infertility. This isn't just some rare isolated disorder. We're talking about a widespread metabolic and reproductive challenge.
And this brilliantly illustrates one of the biggest clinical misconceptions out there. You know, the syndrome gets its name from the many fluid-filled sacs, cysts, that often develop in the ovaries, causing them to enlarge. But here's the catch. Having ovarian cysts alone is not enough to make a diagnosis. Seriously. You can have cysts without having PCOS. And actually, some women with PCOS don't even have prominent cysts. It's a syndrome. That means it's a whole collection of systemic issues, not just a localized problem sitting in the ovaries.
Which brings us to Section 2, the hormone and insulin link, the biological cascade.
In so many women with PCOS, we see this condition called insulin resistance. Let's break that down. Normally, insulin helps sugar, or glucose, pass right into your cells to be used for energy. Simple, right? But when cells resist this effect, all that sugar just kind of hangs around and accumulates in your blood. So in a total panic, the pancreas pumps out even more insulin, trying to force that blood sugar down. This state of excess insulin and prediabetes, it's a real game changer. It can lead to serious weight gain, and if a woman with PCOS and obesity becomes pregnant, it significantly increases her risk of complications, like gestational diabetes, preterm delivery, or even preeclampsia.
And, you know, this insulin issue is really just one piece of the puzzle. The biological cascade of PCOS is literally like a hormonal domino effect. Evidence suggests it all kicks off with a malfunctioning enzyme that controls male hormone production, causing androgen levels to just spike. These high androgens drastically increase the risk of metabolic syndrome, bringing things like high blood pressure and cholesterol along for the ride. Plus, some of these male hormones actually convert to estrogen. Without enough progesterone to balance it out, the uterine lining can become extremely thick, which elevates the risk of endometrial cancer. It even increases the risk of non-alcoholic fatty liver disease. It's a true full-body systemic cascade.
Moving on to Section 3, recognizing the symptoms, from the inside out.
Now, you might be wondering, why on earth does one single syndrome cause so many wildly different issues? Well, the answer lies in exactly what we just discussed. Because the hormones and insulin travel through the bloodstream, they're not staying put. They affect virtually every tissue in the entire body.
This widespread impact leads to a really diverse array of symptoms. Because ovulation gets disrupted, women often experience irregular or sometimes entirely absent menstrual periods. Those high androgens we mentioned, they cause masculinization effects. Think severe acne and hirsutism, which is excess body hair, usually popping up on the face and chest. And what about that excess insulin? Yeah, it makes losing excess body weight incredibly difficult, and it can even cause a condition called acanthosis nigricans. That's where the skin in areas like the armpits or the nape of the neck becomes noticeably dark and thick. And hey, we absolutely cannot ignore the real human toll here. The fatigue, sleep apnea, anxiety, mood swings, and depression, those are very real, very heavy clinical manifestations of this syndrome.
All right, Section 4, diagnosis and rule-outs. The clinical evaluation.
Let's move to and see how this builds into a really organized, step-by-step diagnostic process, because doctors kind of have to play detective here. Step 1 usually kicks off with a thorough evaluation of the symptoms and a routine pregnancy test, just to rule out the most common cause of a missed period. Step 2 involves comprehensive blood tests to measure the levels of those male hormones, blood sugar, and lipids like cholesterol. And finally, Step 3 is an imaging study.
A pelvic ultrasound is typically performed to see if the ovaries contain those characteristic cysts, but also, and this is absolutely crucial, to check for any tumors in the ovaries or adrenal glands that could be secretly pumping out excess male hormones behind the scenes.
Now, what's really interesting about this is how vital those blood tests are for a differential diagnosis. When a young woman presents with irregular or absent periods, a doctor has to carefully differentiate PCOS from other conditions, like premature menopause. With PCOS, we typically see high male hormones, but the ovaries actually still contain thousands of eggs. But with premature menopause, which is the permanent end to periods before age 40, the hormonal profile is completely different. The ovaries produce little to no estrogen, and ovulation completely or almost completely stops.
And unlike PCOS, the causes of premature menopause are usually tied to structural, genetic, or external damage. It can be triggered by genetic abnormalities like Turner syndrome, autoimmune disorders where the body actually attacks its own ovaries, aggressive medical treatments like chemotherapy and radiation, or the surgical removal of both ovaries. The symptoms might feel kind of similar to natural menopause, hot flashes and night sweats, but the underlying mechanisms are totally distinct from the insulin and androgen drivers of PCOS.
Let's jump into Section 5, Targeted Treatment and Management, Tailoring the Approach. So, the crucial point is that medical management depends entirely on what the patient's immediate goals are. It's super customized. For a patient who wants to regulate their cycle and manage symptoms, a doctor might prescribe birth control pills, a progestin-releasing IUD, or medications like spironolactone to block those male hormones. Now, if the goal is achieving pregnancy, the approach shifts dramatically towards weight loss strategies and fertility drugs, like clomiphene or letrozole, to stimulate ovulation. And if the primary goal is combating that metabolic risk and improving insulin sensitivity, the focus turns heavily to dietary changes and diabetes medications like metformin or liraglutide.
But beyond the systemic medications, we also have targeted dermatological and hormonal treatments for those really frustrating physical symptoms. Unwanted facial and body hair can be managed with eflornithine cream, anti-androgens like spironolactone or cyperterone, and, of course, laser hair removal. And the acne caused by PCOS, that's treated aggressively with standard protocols like benzoyl peroxide, tretinoin cream, or antibiotics. Just to quickly contrast this with the premature menopause we discussed a minute ago, a patient dealing with premature menopause requires a very different approach. Because their bodies lack estrogen, their treatment relies heavily on estrogen and progestin hormone replacement therapy, usually right up until about age 51. And this isn't just for symptom relief, guys. It is medically necessary to protect their long-term health and prevent severe complications like osteoporosis, dementia, and coronary artery disease.
Finally, Section 6, Reclaiming Your Health, Proactive Long-Term Management.
Managing PCOS effectively goes far beyond just taking a pill. It requires proactive, daily lifestyle interventions. Exercising for at least 30 minutes a day and cutting back on carbohydrates, the breads, pastas, and sweets, can drastically help lower those insulin levels naturally. It's also absolutely vital to keep up with periodic blood tests to monitor glucose, kidney, and liver function, and perhaps most importantly, please do not ignore the mental toll. Seeking mental health care for the anxiety and depression that so frequently accompany PCOS is literally just as critical as managing your blood sugar.
I want to highlight this quote directly from the clinical guidelines. Decreasing the high levels of androgens in women with polycystic ovary syndrome can help regulate menstrual cycles and improve the chances of pregnancy. I'm sharing this to reassure you. By working closely with your healthcare provider to combine targeted medical interventions with sustainable lifestyle changes, you absolutely can restore balance to your body. There for sure is a path forward.
I want to leave you with this final provocative thought. What steps will you take today to advocate for your reproductive and metabolic health? Knowledge is hands down your best diagnostic tool, and I really hope this explainer has equipped you with exactly that. If you found this breakdown valuable, please take a quick second to like, share, and subscribe to the MediByte channel for more medical insights. Your support is what helps us keep creating these deep dives. Until next time, stay curious and stay healthy.